This is Where We Live. I'm Lucy Nalpathanchel. Stigma still surrounds HIV/AIDS. In some parts of the world, it's still a dominant killer. But in the U.S. and in many Western countries, it's a disease that no longer is equated with an automatic death sentence. New diagnoses are down in this country. The CDC says over the last decade, there's been a 19% decline in new cases. Today, Where We Live, we look back over the last 35 years since the discovery of HIV/AIDS. UConn has 3 current exhibitions tracing the progression of the disease, and we'll talk with one of the curators about what's included and what prompted his interest. Later, we'll be joined by Connecticut residents living with HIV, one diagnosed before a consistent treatment was introduced, another after the introduction of successful antiretroviral medications. And we'll talk with a Yale researcher about the advances in HIV/AIDS prevention. Are you living with HIV or know someone who is? What did the diagnosis mean to you? And how are you living with the virus or the disease? We want to hear from you. Join the conversation, 860-275-7266. As always, you can comment on our website, wnpr.org/wherewelive. You can find us on Facebook and Twitter @wherewelive. Joining me now in studio is Dr. Thomas Lawrence Long, Associate Professor in Residence in the UConn School of Nursing and curator of the school's Josephine A. Dolan Collection of Nursing History. Welcome to Where We Live, Tom.
Thank you very much, Lucy.
So there's 3 exhibitions at UConn this fall that focus on HIV/AIDS. Where did this idea come from?
Well, a couple of years ago, I taught a course at UConn on AIDS and culture. And one of the things that struck me was that most of our undergraduates have never lived in a world without AIDS. And it also struck me that many of them were completely unaware of the struggles that HIV-infected people and their friends and family encountered during the worst years of the 1980s. And I knew that they needed to understand that history of activism, the history of government inaction during much of the 1980s. And so as we approached this 35th anniversary, I began to talk with curators in the UConn Archives and Special Collections and the Benton Museum of Arts in order to mark this important milestone. At the same time, the National Library of Medicine has a traveling exhibit that was available at this time as well.
So there's 3 exhibitions. What will people see when they go to the school?
Well, when they go to UConn's Archives and Special Collections in the Dodd Center, they're going to see a special exhibit prepared by Graham Stinnett, who is the archivist for human rights and alternative publications. They're going to see an exhibit of alternative publications related to the AIDS epidemic. Early in the AIDS epidemic, it was grassroots organizations that prepared safer sex and risk reduction printed materials. It was alternative presses and alternative publishers that published some of the first novels and plays related to HIV/AIDS. When they go to the Benton Museum in the balcony gallery area, they're going to see a very fine exhibit curated by Jean Nihoul, one of the curators at the Benton Museum, that is related to, well, we're calling it visual AIDS, and it's directly related to art, graphics, images during the HIV/AIDS epidemic's worst years, as well as some what we might call post-AIDS, representations of the body and sexuality that emerged from that. Finally, in the School of Nursing, just opened this week, people will see the National Library of Medicine's exhibit, as well as an exhibit case that I've prepared of artifacts related to nursing and nursing care. Safer sex and risk reduction materials, educational materials, popular culture, video, fiction, film, some of those kinds of artifacts.
You have an interesting perspective in the 80s when HIV and AIDS was first discovered. Tell us about what you were doing.
Well, I have 2 deep connections to AIDS. During most of the 1980s, I was a Roman Catholic priest in the Diocese of Richmond, Virginia, and I was one of a few clergy who could be reliably called upon to minister to people living with AIDS and to their partners and families and friends. So I was spending a lot of time in hospitals, with people at their homes, and a lot of time in conducting funerals and memorial services. At the same time, as a gay man who during the 1970s had done a lot of things that put me at risk for HIV infection, I constituted part of a cohort of my generation that were known as the worried well. We didn't know if we were infected. We all assumed we were infected. There was a debate about whether it was even worth taking the HIV test because there were no adequate treatments for managing HIV. So it was a time of tremendous grief and a time of tremendous anxiety for me and for many others.
Can you walk us through the stigma that surrounded HIV/AIDS, especially how society viewed gay men at the time?
Well, let me give you one very pointed example. As you are no doubt aware, the Republican administration of Ronald Reagan was entrenched in a kind of conservative Christian fundamentalist mentality, resisted providing AIDS education. Early on, and in fact, it wasn't until 1987, when tens of thousands had died from AIDS, that Ronald Reagan even mentioned AIDS at a press conference. Early on in the epidemic, reporters asked Larry Speakes, Reagan's press secretary, about AIDS and about the administration's response to AIDS. And Speakes laughed and said to them, "I don't know anybody with AIDS. Do you?" So that was the kind of, it was a joke. People living with AIDS were the object of disdain. In the 80s, we also coined an additional epidemic. We said we also have an epidemic that we called afraids, acute fear regarding AIDS. And so there was enormous anxiety. There was enormous anxiety among healthcare providers like physicians and nurses who often were very anxious about the possibilities and unclear about the vectors of transmission themselves. So there were many ways in which people with AIDS were marginalized. People thought you could become infected with the virus by casual contact. And people were often left on their own, abandoned by their families, which is why grassroots organizations arose to provide AIDS care, the so-called AIDS service organizations.
This is Where We Live. I'm Lucy Nalpathanchel. I'm speaking with Tom Lawrence Long, Associate Professor in Residence in the UConn School of Nursing. UConn has 3 exhibitions at the university that's opened in the fall, looking back 35 years since the discovery of HIV/AIDS. If you have a question or comment, 860-275-7266. You can find us on Twitter and Facebook at Where We Live. Tom, you mentioned that for a time you were a priest. You were also a gay man. What led you to leave the priesthood?
Well, it's interesting, Lucy. You're not old enough to know this, but you can spend decades sorting out why you did something and decades sorting out why you decided to stop doing something. So a few years ago, my answer to that question, I formulated it very simply. I left the ministry and the church because of women and sex. I found myself in irreconcilable differences with the Roman Catholic Church on a whole range of issues related to gender and sexuality, including birth control, artificial contraception for married people, divorce and remarriage, priestly celibacy, the role of gay and lesbian people in church, a whole range of issues. So I've boiled it down to that one formulation.
I was curious because, obviously when we talk about the importance of safe sex, the tenets in the Catholic Church, they believe, not in promiscuity, sex, wait till sex for marriage, and that's just not the reality. And so seeing, being in the priesthood in the 80s, seeing the education around this virus, the role of the church, when we look at the global epidemic of people dying, the message that the church sends versus what people are doing every day. There's just quite a conflict there.
Well, there is a conflict, but Lucy, here's the paradox. Throughout the 80s and 90s, according to reliable social science information, Roman Catholics, among all Christian groups, Roman Catholics were among the most pastorally sensitive and pastorally supportive people. Roman Catholic healthcare institutions, in many instances, rose to the challenge of providing adequate health care for people living with AIDS. So there are these contradictions and contrasts. I certainly don't want to paint the Roman Catholic Church as being an entirely evil empire, but there are these contradictions.
This is Where We Live. I'm Lucy Nalpathanchel. So when we talk about this exhibition, of the three, which one do you find yourself drawn to?
Well, I would be less than loyal to the to the exhibit that I prepared myself. It was very gratifying to me when last week I finished installing the National Library of Medicine's exhibit, and one of our a graduate students, she's a doctoral student of mine, Saja Jackson, is a nurse practitioner here in Hartford. Who has been working with HIV/AIDS care and urban health care for the last 30 years. She contributed a number of the objects on display, including things like safer sex packages and promotional and educational materials. So I'm very pleased with that exhibit in the School of Nursing.
We're focusing on 35 years since the discovery of the virus, but it's also the 20th anniversary of a very important milestone in the path to treating people. Talk about that.
Lucy, overnight in 1996, the introduction of protease inhibitors and other antiretroviral medications, and you've got speakers later today talking about that, overnight, what had been a death sentence, HIV infection was a death sentence. Overnight, it simply became a manageable chronic infection. Complex, of course, but a manageable chronic infection. And that changed the landscape entirely. I had a student at the time, probably about 1997, who said to me, I've spent the last several years preparing to die, and now I have to somehow figure out how to live. So it was a tremendous turning point in people's lives.
I'm speaking with Dr. Thomas Lawrence Long, again, Associate Professor in Residence in the UConn School of Nursing and Curator of the school's Josephine A. Dolan Collection of Nursing History. He joined us today to talk about some current exhibitions at UConn that trace the progression of HIV/AIDS over the last 35 years. Tom, so nice to meet you. Thank you for coming in.
Thank you, Lucy. It's been a great pleasure.
More information about the exhibitions at UConn can be found on our website, wnpr.org/wherewelive. Coming up, a conversation with a Connecticut couple. One spouse has HIV, the other is HIV negative. We'll find out how they've navigated the ups and downs of her diagnosis. And later, a researcher will be here to tell us about the advances in medicine that has given hope to many people living with HIV. Join the conversation, 860-275-7266. This is Where We Live. I'm Lucy Nalpathanchel. Today we're talking about HIV/AIDS. It's been 35 years since it was discovered. At the time, there were many unknowns and a lot of fear. I watched a lot of NBA with my dad when I was a kid, and I remember that day when Magic Johnson said something that was pretty courageous for the time. It was 1991 when Johnson publicly admitted to being HIV positive, and he admitted to contracting that virus from heterosexual sex. That changed perceptions from a society that believed largely that HIV/AIDS only affected gay men. Someone who can talk about this on a more personal level is Karina Danvers. She's director of the New England AIDS Education and Training Center, regional partner at Yale University AIDS program. She's also HIV positive. Karina, welcome to Where We Live.
Thank you.
Also in studio with me is her husband, Larry Danvers. Welcome to Where We Live, Larry.
Good morning, Lucy.
And joining us from NPR studios in Washington, D.C. is Dr. Robert Heimer, member of the Center for Interdisciplinary Research on AIDS at Yale and a professor at the Yale School of Public Health. Dr. Heimer, thanks for joining us today.
Good morning.
I'll turn first to Karina. I brought up Magic Johnson's announcement because that was 2 years after, I believe, you found out that you were HIV positive in 1989. Tell us about that moment.
Well, just listening to you talk about that moment just gave me goosebumps because I remember being grateful that someone that people weren't going to hate and men could relate to him, women wanted to be with him, and it was someone who people were just really shocked, and it just opened the door for some of us who felt that we couldn't tell anyone. He just opened the door for, quite frankly, heterosexual people to be able to talk about HIV/AIDS and sort of not normalize it because it shouldn't have been not normalized to begin with. But middle America, so to speak, was able to now see, oh my goodness, this is a disease that can hurt all of us and it can infect all of us. And it was so courageous. I have always said, I always do this in presentations, I think Magic Johnson saved thousands, if not millions of lives around the world by having come out as early as he did.
So at that time, you knew for about 2 years that you were HIV positive?
Yeah, by exactly almost 2 years. I was diagnosed in October 10th, 1989 in Orange, Connecticut. So right here on the Post Road in Orange, Connecticut. And Monday morning at 9 a.m., I was actually working at the School of Medicine at the time, and I received the phone call from my doctor to let me know I was HIV positive. In those days, the test to get the results back took about 3 weeks because they had to mail the blood out of state to New Jersey to actually have it confirmed for a positive test. Nowadays, you can find out within 20 minutes. And it's free in most places, or your insurance can cover it. And you don't have to be afraid of having health insurance. It's such a difference. It's such a difference. And this time of year is very emotional for me because my whole journey with HIV really started on September 26, 1989. And it sort of ended by my diagnosis on October 10th of 1989. So it's almost been 30 years.
What prompted you to get tested?
The only thing that prompted me, because I was one of those people who said by 1992, we're all going to know somebody who is HIV positive. But when I would look at myself in the mirror, not once did I thought I would be one of those people. Why? Because I was heterosexual. I had only a couple partners. And the only reason I got tested is because my ex-husband's mom called me, and she told me that my ex-husband was dying of AIDS, and that his doctor thought I should get tested since I was of childbearing age. That was it. I had no symptoms. Probably by now I was infected for about 5 years. Most likely I got infected in 1984. I had no symptoms. I had no reason. But at the same time, I did not put myself in that category of those people who could be HIV positive. If she wouldn't have called me, I probably would have been an individual who ended up in the hospital symptomatic with AIDS, not just HIV positive, but a diagnosis of AIDS. And in those days, most likely I wouldn't have survived. So but that story in 2016 is still happening right here in our wonderful state that has so many amazing programs. In 2016, if you don't test and if you don't know that you are HIV positive, you are going to end up in that floor at one hospital in Connecticut with full, symptomatic with AIDS symptoms. So I know it's a 1989 story, but really it's a 2016 story if people don't know their HIV status.
And we're going to talk more later about ways to continue to prevent the spread of this virus. I wanted to turn now to, again, Dr. Robert Heimer, member of the Center for Interdisciplinary Research on AIDS at Yale. From a researcher's perspective, Dr. Heimer, talk to us about the understanding of HIV/AIDS and how that has evolved over the past 35 years.
Well, I think the previous guests have alluded to it, but when AIDS first emerged, it was a disease in which people were healthy 1 week, sick the next, and dead a month later. And it terrified people within the communities that were most affected. And we haven't yet talked about people who inject drugs as one of the most affected communities. And certainly in Connecticut and in the big cities of Connecticut at that time, most of the HIV cases were related to unsafe injection drug use. So one of the things that Connecticut did very early on in 1990 was to experiment with syringe exchange programs to curtail the transmission of HIV as a prevention measure. Connecticut actually led the way nationally in doing this, being one of the first 3 or 4 places in the country to have legalized programs.
You mentioned needle exchange. I think we saw just in the last couple of years, was it Indiana, that there was some hesitancy to have the needle exchange program, and then they saw a rise in HIV/AIDS?
There is still, across the nation, massive barriers to needle exchange programs in many places where they're necessary. Federal funding for needle exchange programs has been unavailable for most of the 35-year history of HIV through legislation imposed upon health departments and AIDS service organizations by federal law. Local governments, state governments have stepped up to fill some of the gap, but there are still many places like Scott County, Indiana, where once HIV enters communities of people who are at risk, there's large-scale, epidemic spread of this virus before people come to their senses. That finally happened in Indiana, but Mike Pence, our Republican candidate for vice president, was opposed to needle exchange for as long as as long as he's been on record, and only changed when the pressure became very intense. And it's terrible that the pressure that has to come is at the cost of people getting infected, hundreds of people.
Can we talk about the evolution of treatment? I'll turn back to Karina, who found out in 1989 that you were positive for HIV. So what was available to you then, and obviously compare it to what we have today?
My goodness. The only thing available that was FDA approved was AZT. And unfortunately, a great drug at the time. It was the only thing. It saved many lives. Unfortunately, I was one of those individuals who AZT, just the side effects were just too much to take. And unfortunately, I only lasted barely 3 months on AZT, and then I had to stop taking it. So it was not for another 4 years since and the next drug came out, Xerit D4T, and I was able to do very well. But then that only lasted for 2 years. And many people who are HIV positive from the 80s can relate to the story, which is we tried one drug and then it became resistant. We tried another drug because we started with monotherapy. Now we know that monotherapy doesn't work. But now, I'm on this new regimen, 3 medications. And quite frankly, it's just astounding to me that I don't even have any side effects from it. It's just unbelievable the past 10 years how we gone from unable to even live with the medications because the side effects were so bad, although they saved our lives, to really taking really potent medications and really not even feel like you're taking them. So really great strive. So anybody who's HIV positive, afraid that they have heard the stories about the side effects from the medications, I can really honestly tell you that in the past 10 years, we've just done tremendous work.
This is Where We Live. I'm Lucy Nalpathanchel. Today we're talking about HIV/AIDS. Karina Danvers is in studio. She's HIV positive. Also, she is director of the New England AIDS Education and Training Center. Karina, you're here with your husband, Larry. I'm curious, tell us a little bit about your love story, Larry. I'm putting you on the spot now.
Yes, you are. We met back in the early 90s. And at the time, we were just friends, and I did not know of Karina's HIV status. And we later became involved with each other romantically, and that's when she revealed to me her HIV status. And to me, that was quite a shock because at that time, I just understood HIV to be a death sentence, as others have discussed. And that was very difficult, entering into a relationship with someone who you assumed would be only around for a year or two. So that was, I wasn't as concerned with because once Karina did reveal to me her HIV status, I became aware of how much knowledge she had gained. She had done a lot to educate herself and become involved with it. It wasn't the actual fear of the physical infection that bothered me because she was knowledgeable and knew how to prevent that. It was the emotional strain of, becoming involved in a relationship that you felt was doomed to end within a year or two. So that was a very difficult place to face.
So when did you reach that turning point where you could see yourself retiring happily?
Yeah, that's a good point you make because, in the first, let's say, 4 or 5 years of our relationship, we had discussions about how we'd do her funeral, what she wanted, end of life, what treatments to give her towards, the death, you might say it was impending, to now our discussions are about retirement, saving for, that future. And it's just been a wonderful transition. In the first few years, as Karina was talking about getting on a monotherapy, the drug would fail. She'd get on a medication, things would improve, she'd get back some T cells, her viral load would go down, and next thing you know, the drug would fail and we'd be just facing that impending doom again. But we've been very fortunate, and I must admit it's sort of been put really in the back of my mind in the last 10 years that the miraculous change that we've gone through. It's just really warming.
Larry, we talked a little bit about stigma for people who have been struggling with HIV and AIDS throughout the years. But for someone who's in a relationship with someone who's HIV positive, if you mention that to people, how did they respond to you?
I didn't, frankly, in the first, 10, 15 years we were together. No, I didn't mention it to people. It felt like, it was a very private thing for one thing, discussing it. But secondly, I was afraid of reactions. And, one story I can tell you is I have 2 now adult children who were from a previous marriage. And we were very careful not to have my ex-wife at the time find out that Karina was HIV positive because we were afraid she would try and put barriers towards the children visiting us. And then when we finally did tell my youngest daughter, it was like, "Oh, I know," she said, which was really amazing. She hadn't, when she'd found out that Karina was HIV positive by Googling her, it had not changed her opinion at all, which was, that's the change we've seen, I think, particularly in the younger generation who now have grown up with the Magic Johnsons and people like that being out and knowing that A, it's not a death sentence, and B, it's something you just have to deal with,
Dr. Heimer is also a professor at the Yale School of Public Health. You heard Larry talking about how he's seen the shift in public opinion. What do you believe, Dr. Heimer, has changed people? What do you believe has helped, change people's perceptions of this virus and disease?
I'm not sure the perceptions have changed all that much in many places. I think there's still a good deal of stigma around HIV, that there are places where it is difficult to admit it. I appreciate the benefits of the Affordable Care Act, which has allowed AIDS not to be seen as a pre-existing condition that might result in loss of insurance, which has certainly been a benefit, and the Disabilities Act, which was supposed to do the same thing earlier. But I'm not sure that it has changed all that much. It is just much below the radar because it is a chronic disease now and not an acute disease with so visible a death toll. But there are probably places, and we are exploring this through our work at CIRA, that is trying to find just where such pockets of disease are still festering, existing in ways that we can bring the resources that do exist in states like Connecticut and Rhode Island and Massachusetts to bear on the disease that's not being effectively treated. Corinne is very correct that if you get treatment, your viral load will most likely be undetectable. You can proceed with a normal life, but that those steps from starting with getting people tested to getting people in care to getting people adherent to their medications so that their viral load becomes undetectable is not a straightforward set of steps. There are plenty of barriers there, including the ways resources are allocated, and so we're working to try to identify in at least 9 of the small cities in Connecticut, Massachusetts, and Rhode Island where those barriers exist spatially, where the stigma still exists, where people are reluctant to come into contact with care systems, with treatment systems, with prevention systems.
This is Where We Live. I'm Lucy Nalpathanchel. We're going to head to break. When we come back, we'll learn more from Dr. Heimer about the medical advances in treating HIV/AIDS, and we'll find out how the virus is still disproportionately affecting particular populations. Are you living with HIV? Have you seen perceptions change about the virus or AIDS? Or do you still wrestle with that stigma? You can join the conversation, 860-275-7266. This is Where We Live. I'm Lucy Nalpathanchel. Coming up Thursday, zero-tolerance policies send a strong message to students, but at what cost? On the next Where We Live, we examine how over time these policies have led to suspensions and expulsions for minor issues. What's the long-term impact on a child's future? Join the conversation. That's on Where We Live Thursday. Today we're talking about HIV/AIDS. It's been 35 years since the virus was discovered. More than 1.2 million people in the U.S. are living with HIV today, according to the CDC. 1 in 8 of them don't know they have the virus. In studio with me is Karina Danvers, director of the New England AIDS Education and Training Center, regional partner at Yale University AIDS Program, her husband Larry Danvers, and Dr. Robert Heimer, a member of the Center for Interdisciplinary Research on AIDS at Yale and a professor at the Yale School of Public Health. He joins us from the studios of NPR's headquarters in Washington, D.C. Before the break, Karina, I mentioned, there's still the virus and the disease are still impacting particular populations. Can you tell us about the groups most prone to infection here in the U.S.?
In the U.S. and Connecticut, is men who have sex with men, minority men, Black, Hispanic. It's really the numbers are going up, and they've been going up for the past few years. Younger, also too in certain parts of the country, Florida, for example, the older also population, the numbers percentage-wise are also going up. But right here in our state, and specifically in Connecticut, men who have sex with men, minority, Black, Hispanic men. However, once again, those are the bulk of the numbers, but nevertheless, we're still having basically anyone who has unprotected sex. As Dr. Heimer said, substance use is a big risk too. We've done a great job in Connecticut, as Dr. Heimer was saying. We've done a really great job with the substance abuse population, but nevertheless, there's still pockets available.
You mentioned young gay men. Why is there more diagnosis in that population?
Historically, I think it's a and Dr. Heimer can speak more of this, but I think we forget history. We forget history, and we forget what has happened. Also, younger people are really just, unfortunately, at that when we're young, we just think we're invincible, and we take more risks.
Dr. Heimer, did you want to add something?
Yeah, I think one of the interesting things that research has revealed is that people end up becoming more adherent to prevention after they become HIV infected. Mm-hmm. It seems counterintuitive. You'd think you'd want to protect yourself, but it turns out that people who are not infected are much more likely when involved with intervention programs that have tried to get them to change their behaviors. They don't do that. They continue with risky behaviors. They do change once they get infected. They're much more interested, it seems, in preventing other people from getting infected than initially protecting themselves. Why this is, I still find a fascinating topic of necessary research. Why does what's called secondary prevention, working with people who are already HIV positive, work so much better than working with people who are still at risk of becoming infected? But I can't answer that question.
Robert, I don't know if you agree with me, but I just think it's really difficult for people to think that they could possibly be infected with this disease, who really, it's always been put in such a shadow of they versus us. Usually when I do presentations, and I'm sure this is true of you, I talk to nursing students, anyone who will listen, I'll talk to. And I always say, how many of you really, truly believe that you could become HIV positive? And maybe one or two hands go up. So it's really that perception that there's no way they belong in this category. Just like me. I mean, I really thought that this category was never going to touch my life. And I think it's just really difficult for people to really believe that they can be touched by this disease.
So drill it down for us. Remind people, how is this virus transmitted?
Okay. Sex. And what's important about sex is that everybody has a very definition of what sex is. So it really has to be, I always talk about the plumbing. So it's vaginal, anal, oral, although there haven't been any diagnosis data. And Robert, you can back me up on this, oral sex transmission, but anal and vaginal fluids. So kissing, no data on transmission there either. So those are the substance use, needle, not only the needle, not only the syringe, but the works too, the cotton, the cooker. So those are key ways. Also, mother to child transmission, which of course in Connecticut we haven't had a positive child in I think over 10 years, specifically because we have a law in Connecticut that tests all the, if you're pregnant, you go to your doctor. This is for women who get prenatal care, and they will ask you to test for HIV. And women don't seem to ever decline being tested for HIV. So, and then they get tested the last trimester because, pregnant women actually have sex while they're pregnant, so they could become HIV positive. So those are the modes of transmission. Vaginal, anal sex. And I always say it's not gay or straight sex. Anal sex, there's heterosexual couples who also practice anal sex. So it's just about the plumbing. It's really not about putting people in categories about homosexual or heterosexuals.
I wanted to bring into the conversation. Oh, go ahead, Dr. Heimer.
But I would like to add one thing about why gay men seem to be so much at risk. Some of my colleagues at Yale have been working on trying to understand this, and in thinking about it, I think what they're concluding is that for many gay men, there's probably more stigma related to being gay than there is to being HIV positive. Because HIV positive, it's treatable. Being gay puts you at certain disadvantages in society, despite the progress that we've made with gay marriage and in other areas of life, but there's still a great deal of stigma about not conforming to the male stereotype. And when you're young and you're trying to deal with this issue, sex is a release from that, and so that may explain why unprotected sex is still so common. And HIV transmissions still are occurring at such a high rate in young communities of men who have sex with men.
We're getting a tweet from Sean who writes, "We don't have gay hubs anymore, and social media apps are how young men who have sex with men connect. It makes prevention challenging." I wanted to bring into the conversation now LaToya Tyson. She's Prevention Program Manager at AIDS Connecticut. LaToya, thanks for joining us by phone.
Thank you for having me.
I'm sure you're able to hear part of the discussion. Karina was saying that, there's still that belief out there that, a lot of people think this virus, there's no way I'm going to get HIV. Talk us through when you found out you were HIV positive.
I was 19. It was February 18th of 1999, and I had been in a 5-year relationship. So it was very devastating for me because, back then we still had a misconception of who and, what kinds of people contracted the virus. I was not considered a high-risk individual, and so to have that status, being placed on me was very detrimental to my mental health at the time.
And how did you move forward when you got that diagnosis?
A lot of prayer. I'm a very spiritual person, and so I had to do a lot of introspection about myself, about the role I played in contracting the virus, and learning how to forgive not only my partner for being dishonest with me, but myself for decisions that I made and choices that I made.
When you found out you were HIV positive, you also had 2 children at the time?
I did.
So how did your family react?
Very horribly, actually. I am my mother's only daughter, and their perception of HIV was very skewed because as far as my family knew, they didn't know anyone that was HIV positive before me. So my mother was extremely devastated, and for the first time in my almost 40 years of life, I had actually seen my mother cry, and I had to become the educator in my house because she immediately, once she got over that initial shock, thought and actually said out loud to me things like, washing my clothes separate and buying me plastic silverware and utensils and things. And she was very explicit about me not kissing my sons for fear that I would, give them the virus as well. But I had to first become an educator internally, educate myself about the virus, about exactly what's going on in my body, how it's affecting me, how it transmits and versus how it doesn't, and then in turn do the same to my family.
We know that the virus disproportionately affects minority groups, particularly members of the African American community. You said that you're an educator with AIDS Connecticut. Tell us why this virus is still impacting African Americans this way.
Just culturally speaking, there I think are a lot of different factors. Women especially have a tendency to leave their sexual health in the hands of their partners, believing that is their responsibility as the man. Culturally, we're kind of taught that. In terms of MSM, homosexuality or homosexual behaviors are extremely, extremely taboo. And in a lot of different African American cultures, you can even be killed because of it. And so people just they would rather do their stuff behind closed doors and not actually have conversations with their partners about what their preferences are or, what their practices are and what they prefer. So I think there are lots of different factors, including limited access to health care and things like that, and even to education for that matter.
Because you're an educator with AIDS Connecticut, lots of different events that you hold to send the word out to the community about prevention and treatment. Can you talk about some coming up?
Oh, there are quite a few coming up. Of course, some of the colleges have called us. So Central Connecticut State University has called to ask us to go out there. So has Eastern. We also have, of course, World AIDS Day that's coming up on December 1st, and we're going to be doing a lot of things there. It's kind of difficult to tell you where because, folks call us, in a week and they want us to go somewhere, the next week. So, we're always taking our request very seriously about going into different venues. We recently were in a couple of the YMCAs here in Hartford. We've actually gone into a couple of the churches recently. So we're all over the place.
Well, I do want to thank you, LaToya, for calling in, and we're glad to hear that you're doing well so many years after your diagnosis. On our website, WNPR.org/where-we-live, we're going to have information on an AIDS walk that's coming up from AIDS Connecticut. LaToya, thank you so much for your time today.
Thank you very much for having me. I really appreciate it.
I did want to turn back to Karina because we're talking about prevention and just with the evolution of certain treatments available, something called PrEP. Can you talk about that?
Oh, PrEP, yes. It was approved by the FDA in 2012, and it's right now it's only one drug that's been approved, Truvada, and it's pre-exposure prophylaxis. So it's the same kind of medications that we take as HIV-positive individuals, but this medication, pre-exposure, is for people who are HIV negative, who want to prevent from acquiring HIV. It's not 100%. It's 96%. And it has to be taken every day, although there is other trials going to see what's called PrEP on demand, which is a special schedule when you take it if you know when you're about to have sex. It's shown to be very promising from people getting infected with HIV. Some might consider that, for example, Larry and I would be a good candidate for that since I'm positive and my husband is negative. And I'm going to embarrass my husband right now. And he is, since the data has come out about being undetectable, if you're HIV positive, undetectable, and you are adherent to your medication and you've been undetectable for a while, that they're saying that transmission could be next to zero without protection. And so if you add PrEP to, for example, our relationship, basically, you can never say zero, but it would be almost impossible to transmit the virus. My husband very much would like to do that, and I'm a product of the 80s. I saw too much death and destruction, and the thought that I could infect someone, even if there is almost negligible chance, for me, condoms in my lifetime will not come off. However, PrEP is a great tool for people who would like to take that extra precaution. PrEP actually, Truvada, the medication, is actually recommended to use along with condoms. So this is not supposed to be. However, most people are using it without the condoms.
And we're almost out of time. I want to turn back to Dr. Robert Heimer. We've been hearing a lot about just the breakthroughs over the last 35 years. Because you're a researcher, what's happening right now that really excites you about how we're going to continue to treat this virus?
Well, I think right now we have a cocktail of three drugs for treating the disease that work extremely well. The current regimens include enzymes that prevent the conversion of the viral RNA, the genetics of the virus. The genes are encoded in RNA that has to be converted to a DNA copy before an infection can take root. We have drugs that prevent that step. Then the DNA has to be inserted into the host chromosomes. We have drugs that block that step. Those are the drugs involved in the current regimen. But I think what's most important change is when we start treatment. Right now, the guidelines are if you are HIV positive, you should be in treatment. It used to be we waited till some threshold that you crossed in terms of the disease progression before we started you on treatment. That's no longer the case. We detect the virus in you, we treat you. Those should occur in lockstep. As Karina was saying earlier, these drugs have so little side effect that we don't have to worry about the negative effects, about the drugs becoming ineffective. So we might as well treat now everybody who's positive. That will also prevent secondary transmissions from the people who are infected. If their viral load is undetectable, then the virus will not be spread to others. So get tested, get treated, and enjoy sex.
We'll have to leave it there. Not a bad place to end it. Dr. Robert Heimer, member of the Center for Interdisciplinary Research on AIDS at Yale, professor at the Yale School of Public Health. Thank you also to Karina Danvers and Larry Danvers. Thank you so much for sharing your story. We'll continue the conversation on our website, WNPR.org/where we live. Our show is produced by Lydia Brown and Jeff Tyson. Our technical producer is Kyone Wolf. I'm Lucy Nalpathanchel. Thanks for listening.